Hello, everyone, and welcome to today's SADS Experts Insights webinar. My name is Guido McGuigan, and I'm the new Executive Director of the Canadian SADS Foundation. For those familiar with our work, don't worry, Pam isn't gone yet. So she's here in the audience with us today and will be working with me over the next year as we go on this new journey together. With that being said, this is my first time hosting one of our webinars, so you'll have to bear with me, and hopefully I won't make any mistakes. But I guess we'll see. But we're glad everyone could join us for this important session focused on advancing care and understanding of inherited heart rhythm conditions. I know there are a few registrants from around the world, so wherever you are from, good morning, good afternoon, good evening. But today we're especially honored to welcome Dr. Jason Roberts, who will be making his presentation on evaluating disease-modifying therapy for ARVC, ACM, the target trial. Dr. Roberts is a highly respected cardiac electrophysiologist at Hamilton Health Sciences, an associate professor of medicine at McMaster University, and a scientist at the Population Health Research Institute. As a clinician, his expertise includes treating arrhythmias such as atrial fibrillation, supraventricular tachycardia, and ventricular tachycardia with medications and catheter ablation. He also implants pacemakers and defibrillators. Dr. Roberts leads the Adult Clinical Cardiogenetics program at Hamilton Health Sciences, which provides specialized care to patients and families affected by inherited forms of heart disease. As a researcher, his interests focus on genetic arrhythmia and cardiomyopathy syndromes. He's particularly interested in evaluating the clinical utility of new drugs and gene-based therapies as treatments for these conditions. He's currently leading the Target trial, which is evaluating a potential disease-modifying therapy for arrhythmogenic cardiomyopathy. And today's session, we'll be getting the chance to learn more on that groundbreaking study. So before we begin, just a few housekeeping notes. Please ensure your cameras are off. I think I have everything kind of set to off and muted anyways, but cameras are off, microphones remain muted throughout the presentation to avoid any disruptions. If you have any questions for Dr. Roberts, please feel free to type them into the chat at any time during the webinar. We'll do our best to address as many as possible during the Q&A portion at the end of the presentation. And also a quick reminder that this session is intended for general educational purposes only, and so not for personal medical advice. So when submitting questions, please keep them general and avoid sharing personal or family medical details. And finally, I wanted to mention that our SADS Expert Insights series is provided at no cost, striving to make information on SADS conditions universally accessible for Canadians. As a charitable organization, we rely on your support. So if possible, please consider a donation, as this ensures the continuity of these vital programs for patients and families. With that being said, it's my pleasure to welcome Dr. Jason Roberts.
Excellent. Thank you very much, Guido. It's great to be here. I'm just going to ask to share my slides. And thank you for that very kind introduction. So I'm just asking, sharing is not turned on. If you guys could enable me to share my screen. And I hope everybody's having a great Thursday.
I knew there was going to be something. Why can I not allow you to share your screen? That is a good question. I'll remove from Spotlight and maybe that will make it possible.
Okay.
Can it share now?
No.
That's funny because
oh, here we go. Yeah.
Yep, that should do it.
Great. All right, let's just see. Usually, okay, Microsoft PowerPoint and the slides that I have. Okay, there we go. And we'll change to
wonderful. We're all set.
Excellent. All right, so thank you again, Guido and Pam as well for asking me to provide an update on Target. So a little over a year ago, we had done an initial presentation, and we had thought that trial we'd be able to get everything up and running in a few months, but it took a little longer. It's just research ethics boards. The approval process takes a little while, and contracts and stuff like that. But we're delighted now that the Target trial has officially started. Our site in Hamilton has started enrolling, and there's a total of 17 Canadian sites. Another 6 or 7 will hopefully start enrolling in the coming weeks. So in that overall context, Guido and Pam suggested that we do an update about our current progress, and I thought that was a good idea, and we can run through the background for the trial and some of the logistics or the nuts and bolts behind it. So with that, yeah, so the overview will provide a brief overview of ARVC, or arrhythmogenic cardiomyopathy, talk briefly about the genetics that are involved. That's relevant in terms of who is eligible for the current study. And then talk briefly about our current management of patients with ARVC and ACM, how we estimate risk, who needs a defibrillator, and then how we subsequently manage with medications and ablation. And then highlight with that, I think we do a pretty good job in 2025, but we always want to be able to provide better care for our patients. So we're hopeful that this new medication or this new drug that's being studied, it looks promising in animal models, and we'll go through that data. And we're hopeful that that may translate to human studies. So that's what motivated Target. So in terms of brief background, so we use the term arrhythmogenic cardiomyopathy these days to recognize that these genetic culprits, or these genes, can cause disease in both the right and left ventricles. So ARVC, it suggests it's only the right ventricle involved, but we've learned that a lot of times the left ventricle is also involved, and in certain genes, the left ventricle is predominantly involved. So for target work, because these genes, the genes included, can affect both, we're saying it's a trial for arrhythmogenic cardiomyopathy, but there'll be a subgroup of patients with ARVC. So what is arrhythmogenic cardiomyopathy? There's different definitions, but I view it as a form of heart muscle condition where the risk of arrhythmia is more prominent than would be expected for the degree of ventricular or pump dysfunction. So in a lot of patients that have heart muscle weakness, their main problem is heart failure. But in arrhythmogenic cardiomyopathy patients, although heart failure can be an issue, arrhythmias play a very prominent role in their clinical course. In that context, for people who have typical weak heart muscle that's not arrhythmogenic cardiomyopathy, we usually wait until the pump function, the left ventricular function, the ejection fraction is less than 35% before we put in a defibrillator. In ARVC and ACM, we have a completely different approach to the decision of when we put in an ICD, and it's increasingly becoming gene-based. So it's important to do genetic testing to understand exactly what's driven your heart muscle condition, and then based on that, we tailor care based on the gene. So within ACM, so ARVC is considered the most common subtype. The prevalence of ARVC is generally estimated at about 1 in 5,000. Italy says that their prevalence is about 1 in 2,500. So it's rare, but it's not that rare. In a country like Canada, there's thousands of patients that have it. And the pathophysiology, what happens is the heart muscle, the myocardium, starts getting replaced with fibrosis and sometimes fat. And this leads to a risk, affected patients being at risk for dangerous fast heart rates, ventricular arrhythmias that can sometimes cause cardiac arrest and sometimes sudden death. So the genes that I was alluding to, and these are the so Target is restricted to genotype positive patients. People have asked us if is it possible that this drug will be evaluated in genotype negative patients, and I think if it shows benefit in this study, then one of the next steps would potentially be to look at genotype or gene-elusive patients. But for Target, it's these 6 genes that are involved. So what are the genes? So PKP2 is the main genetic culprit for ARVC. PKP2 usually affects predominantly the right heart muscle, although you can have left ventricular involvement. DSG2 and DSC2, they usually behave in general similar to PKP2, so usually predominant right heart involvement. Desmoplakin, so DSP, and this is why I asterisk it usually, although some patients with a genetic culprit in desmoplakin can have right-sided heart muscle disease, usually desmoplakin patients, it's predominantly the left ventricle that's affected. And then JUP, or I guess we call it JUP, so that's a gene that encodes plakoglobin. So whereas the 4 preceding genes cause disease if there's a single gene is affected. So everybody has 2 copies of each gene. For the first 4 genes, if 1 copy is abnormal, then you can get disease. Generally, plakoglobin, you need both copies to be abnormal. So we say, whereas the other genes cause an autosomal dominant form of the condition, plakoglobin is usually autosomal recessive. So 2 abnormal copies. So those genes are present in the desmosome. So that's a structure that holds cells together. And then the other gene in target is TMEM43. So that's the gene that is most prominent in Newfoundland, and the Newfoundland team has discovered the gene and has helped guide the rest of the world in terms of how to best manage these patients. There's a single letter change in that gene that seems to cause disease, whereas the other genes, there's many letter changes that can cause disease. For TMEM43, it's that single letter change. And these patients that carry this, they often have biventricular involvement. So it usually affects both the right and left ventricle, although there's always exceptions and variations. So this just shows that for the desmosomal genes, where their location is in the cell. So this is just cell membranes here, and it just shows how they hold the cell together. So it's felt that stress on the heart, which may be potentially partially driven by exercise, that can stress these cell junctions, and potentially explains why exercise can help accelerate disease progression and make it worse. So how do we manage patients with ARVC and ACM? I would say in 2025, it's still a big frustration for us when we see family members that possess these genetic variants and don't have any evidence of disease. Patients often ask, great, it's been caught early, so I hope you can prevent it from developing. And unfortunately, in 2025, we're still not at a point where we have disease-modifying interventions. So what we do today, if someone carries the gene but has no evidence of disease, we monitor them. So we do ECG, ultrasound, Holter monitor, and MRI, potentially treadmill test every year, and to see how their clinical picture looks. And assuming all the testing remains normal, no medical intervention needs to be initiated as a general rule. Because exercise can increase the likelihood that disease will develop in the presence of a genetic substrate, we often will counsel patients around exercise restriction, but there's still debate about whether or not patients that are phenotype negative, so no clinical evidence of disease, if they should be exercise restricted. But certainly when patients start to develop disease, then we feel, particularly for PKP2, that they need to be very careful with exercise. In addition, when clinical features start to develop, we usually start a beta blocker because we are hopeful that might slow progression. We don't have great data to say that it's the case, but a lot of people feel that it does. As the disease progresses, and the Holter monitor starts showing more extra beats and runs of extra beats, and if the pump function starts to get weaker, then we have to start worrying about risk of sudden death. And when patients are deemed high risk enough, then we decide an ICD needs to get inserted. So an ICD, they're a great innovation. They help protect patients against sudden death, but the way that defibrillators protect against sudden death is often through shocks through the device. If you get a dangerous fast heart rate, the device has to shock the heart in order to stop it. So that's painful and can be quite psychologically traumatic for patients. So we want as much as possible to minimize these shocks. So how do we do this? We start antiarrhythmic drugs, medications like sotalol, and flecainide, and amiodarone, and they can be good at suppressing ICD shocks and ventricular tachycardia, but they do have the potential for side effects, particularly amiodarone, and they ultimately don't prevent the actual progression of the disease. When patients continue to get shocks despite antiarrhythmic drugs, then we usually have to consider catheter ablation. So that's a procedure where we put catheters inside the heart and map the areas of scar that are responsible for these extra circuits. And by burning, we can often disrupt the extra circuits. Our typical catheter ablations, we go inside the heart and map inside and ablate. For ARVC in particular, the disease often develops first on the outside of the heart and grows inward. So we often, in that context, we have to map not only on the inside of the heart, but also on the outside. So an epicardial approach is also often required. And that can work really well to prevent shocks. And then, so that's from an arrhythmia perspective. And then from a heart function perspective, the heart muscle can continue to get sick, and in some patients, they can go on to develop significant issues with right heart failure, sometimes left heart failure as well, and sometimes heart transplant is needed. But in most patients, the arrhythmias are the most prominent issue, but there's a portion of people that do have issues with heart failure. So this is the risk score that we use for particularly PKP2 ARVC. There's a separate risk score actually now for DSP or desmoplakin. But the ARVC risk score, and this was developed by a Canadian, Julia Cadron-Torigny, who works in Montreal. You plug in a bunch of clinical features for patients, and it gives us an idea of what the risk of having an event is over the next 5 years, and it helps us decide on an ICD. Beyond PKP2, so there's multiple other genetic subtypes of arrhythmogenic cardiomyopathy, as we alluded to, and they all have different approaches for how we decide on the need for an ICD. And this just shows some examples. So these genes here, this was just to emphasize that you can get left dominant arrhythmogenic cardiomyopathy. The genes that are mentioned here actually aren't in target because the molecule that's been studied hasn't really been evaluated in those genetic subtypes. So I think I went through already ablation. So when patients are having issues with arrhythmia, ablation can be very effective through an endocardial and epicardial approach. But in 2025, so I think we do have a pretty good toolkit to try to help ARVC and ACM patients, but ideally we have therapies that can actually slow progression, maybe even halt disease progression, and maybe even reverse disease progression. That's the ultimate dream and vision. So I think, as people know, there's gene therapy programs right now for PKP2 with clinical trials ongoing in the United States, and that's really exciting. And this this target is evaluating a pill, or it's right now, it's actually a powder that people would take daily that we're hopeful might work for a variety of genetic subtypes of ARVC and ACM. So how did all this come about? How did we get to target? So there was this group in Boston and Baltimore used a fish model of ARVC to try to see if they could identify drugs that worked. They recognized that we're still learning about the disease process or the pathophysiology of ARVC and ACM. So they said, we're going to take an unbiased approach where we're going to screen 5,000 compounds, almost 5,000 compounds, against a fish model of ARVC, and look to see if any of these compounds are able to prevent onset of the disease. And I won't go through the molecular details of how they enable this to work, but it was a way to quickly, the model that they use as zebrafish, they're tiny fish that can sit in little wells in a plate. And in fish that developed heart failure related to ARVC, the fish, if you irradiate the wells with light, they would emit a bioluminescence. So they look to see, are any of these compounds, they put a different compound in each well, and they look to see, are any compounds able to prevent onset of heart failure in these fish? And there was one compound or one molecule called SB2 that seemed to prevent onset of heart failure. This molecule, when they prevented onset of heart failure, and when they did a deeper dive as well, all of the molecular changes, the proteins in the cell, it seemed to prevent all of the abnormal processes that were happening both at a kind of animal level, the heart level, if you look at it grossly, but also at a molecular level. So this was really exciting. The same group then looked at this compound SB2 in 2 mouse models. SB2, so the reason for the title here, GSK3, SB2 is a glycogen synthase kinase 3 inhibitor. So glycogen synthase kinase 3, this enzyme, that it's the name of the enzyme is related to its role in glycogen metabolism, which is a type of sugar. We had no expectations that this was going to be relevant really in ARVC or ACM pathophysiology, or the disease process. So it was a surprise, but oftentimes, that's how we learn in science. There's often a lot of unexpected things that come up. So this paper looked at SB2 in 2 different mouse models, so moving from a zebrafish to 2 different mouse models to see whether or not it could also be helpful here, and it was. So in patients, if we look at patients that are treated with the mouse model was DSG2, one of the genes that we had mentioned before. SB2 is the active drug. So if you look at for panel D, ejection fraction, so mice that are given vehicle or placebo, essentially inactive drug or not drug, you can see that their pump function's lower. The average ejection fraction is down around mid-40s. Whereas the mice that are given the active compound SB2, their ejection fraction ends up being not that far off wild type. So wild type means normal mice. Those are the gray boxes here. And then if we look at extra beats coming from the mouse hearts, so active drug is the black bars, and placebo or vehicle are the white bars. So you can see here lots of extra beats in the mouse model that's given placebo, whereas if they're given the active drug, minimal. So these are isolated PVCs, and then this is non-sustained VT, so non-sustained VT also reduced. And non-sustained VT is runs of extra beats from the lower chambers of the heart. So that was really promising. Our group was looking at a gene that may have a nuanced involvement in ARVC called anchorin, and our collaborators at Ohio State had developed a mouse model for these mice, and they develop arrhythmias and cardiomyopathy similar to ACM. So they did similar experiments with SB2 to see whether or not it could be helpful. These mice generally develop cardiomyopathy around 8 to 10 weeks. So here they started giving the mice drug SB2 at 4 weeks, and then looked again at 12 weeks. So you can see here at 4 weeks, pump function is normal. So the main columns to look at are the right 2 columns at 4 weeks. So ejection fraction is the same. This is before disease develops. And then at 12 weeks, you can see the mice that are given the active drug, SB2, over here, the ejection fraction is relatively preserved, whereas the mice that are given vehicle, the ejection fraction is reduced. I told Ohio State a lot of ARVC patients come to us after they've had disease, so it would be interesting to see if things could reverse. So here they let the mice develop cardiomyopathy. So you can see the ejection fraction's lower at 12 weeks, and they treat the mice for 4 weeks. So check again at 16 weeks of age, and you can see the pump function has recovered in the mice given the active drug, where it's not. It stayed low in the vehicle or placebo-treated mice. That's also, so GSK3 inhibition has also been looked at in the Newfoundland form of ARVC, TMEM43. So this was a paper that came out around the same time, and similar findings are observed. So the main thing to highlight here, ejection fraction, TMEM43 mice that are treated with SB2, their pump function is much better than the mice that are treated with DMSO is just placebo or vehicle. And then multiple other electrical parameters and heart size are also improved with SB2. So it seems like it works in a bunch of, this pathway seems to work in a bunch of the genes that we had mentioned, the desmosomal genes, as well as TMM43. So a question was, how do we move this forward? So SB2, it doesn't appear that it's safe to use in humans. So although it works in animal models, before you can move a drug into human studies, there's a very rigorous toxicology studies that have to take place and they take years to do. And it seems like SB2 didn't get through those safety studies. So we had said, okay, is there another potential way to test the idea that GSK3 inhibition could potentially be helpful or is there a way to test GSK3 inhibition beyond SB2 in humans? So it turns out that there is one molecule called tiglusib that is a GSK3 inhibitor that has moved forward to human studies. It was originally tested now, I think almost about 15 years ago. GSK3, this enzyme, it's involved in a bunch of different pathways in humans. And in that context, it was originally studied for Alzheimer's disease and progressive supranuclear palsy disease, so types of neurologic disease. It failed in both of those studies, but importantly, it was found to be safe in humans, which is great. So it's been studied for a couple of other things, and currently it's being studied for a condition called myotonic dystrophy, which is a skeletal muscle disease. So ARVC involves obviously the cardiac muscle, myotonic dystrophy, skeletal muscle. So those patients have significant weakness, and the hope is that tiglusib will be helpful. So the studies for tiglusib for that condition are ongoing. There's been promising results so far, but the full clarity is not completely sorted. So we reached out to the pharmaceutical company that owns tiglusib and asked if they'd be interested or willing to study it in ARVC, and they were supportive and interested. So our colleagues at Ohio State, so Peter Moeller originally was driving this work, and now it's Mona El-Rafay at Ohio State, who's now leading it. So they've tested tiglusib in 2 different mouse models, the original anchorin mouse model, as well as a DSG2 mouse model that Stephen Chelko has. He works at Florida State, and he was involved in the original studies with the zebrafish and the subsequent mouse models that I had shown. So tiglusib seems to have the same benefits that were observed with SB2. So here's a prevention study with the anchorin mouse. So the drug is given before the mice start to develop heart muscle weakness, and the column over to the right is active drug, whereas this the blue here, a second to the right, is mice that are given the placebo. You can see ejection fraction, it seems to be protected or preserved if people are given tiglusib. Same thing with arrhythmias. So the mutant mice, these are mice that are given epinephrine or adrenaline, and that causes them to get extra beats. And the F is PVCs, G is non-sustained VT, and the H panel is VT, so sustained VT. And you can see, comparing to the column second to the right, so that's mice that are given the placebo, tiglusib helps reduce the burden or vulnerability to arrhythmia. It essentially looks, the mice behave like as if they didn't have disease, as if they were wild type. So Stephen Chelko sent his mice from Florida up to Ohio State to get studied as well. And you can see here tiglusib, the tiglusib mice, treatment with tiglusib protects against a reduction in ejection fraction. The vehicle-treated mice, the ejection fraction gradually goes down. We see the same thing with from an arrhythmia perspective. When tiglusib, the mice are treated with tiglusib, the vulnerability to arrhythmia is lower, which is great. And then they also did Taglusib to see whether or not it could reverse weak heart muscle, and it again it does. So here the D panel, the mice are allowed, so the A panel, the mice their pump function has gone down, and after treatment with Taglusib, the pump function goes up. And then reversal study as well, vulnerability of arrhythmia, same kind of thing. So I won't go into detail, but it seems to prevent against arrhythmia, which is great. So with that, this has led us to start the target study. So target involves 100. We plan to involve 120 patients who are genotype positive, so have letter changes in one of the 6 genes that were discussed. Patients have to be having extra beats, so they have to be what we call phenotype positive, and having extra beats in that context. So these patients are randomized to Taglusib or placebo for 6 months. At baseline, they get an ultrasound and a Holter monitor, and then at the end of the 6 months, the Holter monitor and ultrasound is repeated. And we're going to look to see whether or not, similar to in the mouse studies, do we see benefits. So who are the patients that are eligible for entry into the study? So adults, has to be age over 18 years. You have to be carrier of a disease-causing genetic change in one of these 6 genes. As part of the study, you get a Holter monitor at baseline. So some people have asked, can a Holter monitor that's been used in the past few months or been done in the past few months, can that be used for the study? No, it's helpful if people have had Holter monitors in the past few months so that people have an idea of how many extra beats they're having. But once they enter into the study, a Holter monitor will be mailed to patients. They wear the monitor for 7 days. And then after that, the results from the Holter monitor are analyzed. And if there's an average of over 500 beats per 24 hours, then they'll be eligible. We want patients that have had a diagnosis of ARVC for over 6 months. We know that once patients are diagnosed and either exercise restriction or medications are initiated, PVCs often go down during that 6 to 9 months anyways. So we want ideally patients to have a stable burden of PVCs before they enter into the study. Exclusion criteria. A lot of the exclusion criteria are just related to ensuring safety. People that have scar that's not related to the gene. So if someone's had a heart attack before related to a blocked artery and have scar in their heart for that, they're not eligible because the extra beats that they're having could be from the scar from the heart attack. And we'd have no reason to think that Taglusib is helpful in that context. So we want to make sure people's disease is related to the underlying genetic substrate. They need to be on a stable dose of their medications. These medications like flecainide and sotalol and amiodarone can affect PVC burden. So to try to make sure that what we're evaluating is driven by Taglusib or placebo, we don't want them medication adjustments, other medication adjustments that can impact PVC burden. So we want people on a stable dose of these medications. Taglusib can irritate the liver. And with that, liver enzymes can go up. It happens in a minority of patients, and the vast majority of patients, when it does irritate their liver, everything goes back to normal. The liver adjusts. But in that context, we want to avoid people that have liver issues from entering into the study because it could make interpretation of blood work more complicated. There are drugs that, in terms of the metabolism of Taglusib, there's a few drugs that could potentially impact it, so we want to avoid patients being on those. And then the rest of them, kidney function, we don't think kidney function really impacts Taglusib, but this is just from a safety perspective. If people's kidneys aren't working that well, we want to avoid them being enrolled in this early stage study. And in animal models, there's been no impact of Taglusib on pregnancy or on the fetus, but purely for just being cautious given these relatively early stages. we don't want females getting pregnant while they're taking Taglusib, and we also don't want males impregnating females while on Taglusib, just because of the unknown. But there has been no concerning findings from this context, observed in animals, in the animal studies. So the hypothesis, as alluded to with the animal studies, we believe that Taglusib will reduce the burden of extra beats. There's a Holter monitor done at baseline and the repeat Holter monitor done at 6 months. And we're hopeful that the PVCs will just melt away among patients treated with Taglusib, and we'll be able to show a difference relative to placebo. Heart muscle function is obviously really important as well. So all patients get an ultrasound of their heart and echocardiogram at baseline and again at 6 months. And we'll look to see whether or not, similar in the animal studies, if heart muscle function gets better. And then what's really important, but we're not going to be powered in this relatively small trial, is whether or not it reduces risk of ICD shocks and risk of VT. So we're going to be recording these details, but we don't expect enough patients will have these events over a 6-month period to be able to show a difference. That if this initial study is positive, the next study would be a larger study to try to evaluate these outcomes. So overall, it's a pretty simple study, and most of it can actually be virtual. We appreciate that a lot of patients have to drive a long way to go to their genetic arrhythmia clinics in a lot of provinces in Canada. So you potentially only need 2 in-person visits, one at baseline to get your ultrasound, and if you have an ICD, to get your ICD interrogated, and then again at the end of the study, to get a repeat ultrasound at the end of the 6 months, and get your ICD interrogated. But otherwise, everything else can generally be done virtually. The screening process, some sites have consent, have approval for virtual consent, whereas others, the consent to enter the study still has to be done in person, but that may change over the course of the study. The Holter monitor is mailed to patients. The drug is going to be delivered to patients' homes for most provinces. Quebec is an exception. There's some separate rules for Quebec. And the blood work is all being done, can all be done via life labs in a lot of provinces, or other local labs. So we're hopeful it will be not too demanding on patients. So these are the 17 Canadian sites that are participating in the study. So our site, Hamilton, has been activated and is currently enrolling patients. And there's multiple other sites that we expect will be activated in the next couple of weeks. So that's the background about the trial. So with that, I'm happy to answer any questions that people may have. And thanks very much for the opportunity to present.